Well, you watch the big TV stations, and they're all sitting at home, and even with their $1 million systems, they have plenty of problems, Joe. So I think you're doing a heck of a job. So
thank you.
So today, we're going to talk about blood transfusion. I'm going to do a little bit of a review. I'm try not to do the same old, good and bad of blood transfusion. In fact, I'm going to focus mostly on the negative. We all know we need to give blood when we need to give blood for hypoxemia and patients get unstable, but there's so many things that have come out about it. And then I'm going to try to give you each step along the way some fun facts. So we're going to start off with immediate transfusion reactions. And Joe, as you know, they go line by line. It's going to start off with just a very little bit about each one of these: acute hemolytic reactions, then acute non-hemolytic, allergic reactions, and then something you guys have all heard of, transfusion-related acute lung injury, TRALI, and then the favorite other one too, transfusion-associated circulatory overload, TACO. Then I'm going to talk about delayed transfusion reactions. Those I just listed were immediate. You see them almost right away, but the delayed ones happen days, sometimes weeks later. One of them, post-transfusion purpura. And then just going to basically focus on that one today because it's kind of a nice one to talk about. And then I'm going to talk about massive transfusion reactions, people that require a lot of volume of transfusions, a lot of units. And one I'm going to talk about briefly is citrate toxicity. Then we're going to talk about, I think the next one is hyperkalemia, Joe.
Sorry.
I think that's
Sorry.
it. Yep,
Sorry
hyperkalemia. And then, of course, you're all familiar with coagulopathies that happen. And in between every one of these, I'm going to throw in some fun little known fun facts. Hopefully it'll make it a little bit more interesting than your normal blood transfusion talk. And at the end, I've got a whole little small snippet about gaps in our knowledge about blood transfusion. And these are all fun facts as well. So if you guys want to get started. Okay, so the transfusion dilemma, weighing known, this is the article, weighing the known and newly proposed risks of blood transfusions. This is the article that I referenced, the main article that is quoted throughout this entire talk. But in this review article about blood transfusion is 107 references. And I went ahead and left all the references in there. And you're going to see them in the quotes. And so in the introduction here, we'll just get started with, in the United States, red blood cell transfusions are given about 3 to 4 million patients a year. Acute transfusion reactions have been estimated to occur in about 20% of transfusions, about 1 in 5. And with serious reactions, only about 0.5% of the time. Now, the most important roles of transfusion, of course, are life-saving applications where you have severely bleeding patients and life-threatening or anemias, and people getting unstable as well. So basically, your critical level patients are going to get blood, right? But despite advanced and improved resuscitation strategies, when a patient needs blood, the patient needs blood. Transfusion remains virtually the only effective therapy in such patients, meaning there's really no substitute when you have to have it. And so here's a direct quote from that key paper I referenced in the beginning. Although red blood cell transfusion remains a key therapy prescribed by physicians of all specialties, there's actually little evidence base for the current practices. There's no clear indications for transfusion in most clinical settings. So we're going to take a closer look at all this. Also, red blood cell transfusions, the red blood cells, right, they're mainly administered to improve tissue oxygenation. There's no real specific laboratory parameters that consistently indicate the need for red blood cell transfusion. Physicians most often depend on their clinical expertise, and they look at the hemoglobin concentration to give them an idea if they should give blood. Now, the platelets are prescribed for bleeding, mostly after major trauma or during any major surgery or bleeding situation. FFP then is mostly transfused to replace coagulation factors, right? In acute bleeding situations, trauma, liver failure with bleeding, liver transplant, and by the way, to reverse vitamin K antagonist anticoagulation reversals, such as warfarin. If you don't have the time to wait for the warfarin to wear off and a patient has to go to surgery right away, FFP is your go-to thing. It's also used in thrombocytopenia and DIC. And then cryoprecipitate, of course, is used when we need fibrinogen and in cases of liver failure and massive bleeding. All right, so one last thing in introduction. Quote from the paper here, while transfusion is often considered a safe therapy with minimal side effects, in reality, a blood transfusion should be considered as a temporary organ transplant. You should keep that in mind. Many publications over the decades suggest the need for transfusion should be carefully evaluated, used only when possible, and considered as a last resort when patients are unstable and there's a life-saving measure. So, incidence of transfusion reaction. Okay, let's look at the incidence. A precise estimation of transfusion reactions is actually not feasible due to several issues. First, many reactions are wrongly attributed to the patient's underlying conditions and never actually reported. Secondly, you got the clicker there, Joe?
Oh, shit. Sorry.
Secondly, 50% of all transfusions are given in the operating room to anesthetized patients where reactions are more difficult to recognize. Thirdly, many transfusion reactions are not reported, and due to the lack of a rigorous transfusion reaction reporting system in most medical centers. Fourth, of the two types of transfusion reactions, the acute and delayed, the delayed type is often overlooked and commonly not reported. Delayed reactions include multi-organ failure, thrombosis, occurrence of tumors, and post-operative infection, and these are commonly overlooked, as I stated. So let's look at acute hemolytic reactions. Acute hemolytic transfusion reaction, AHTR, is typically caused by immune-mediated destruction of the ABO-incompatible transfused red blood cells. This is the one everybody thinks about where the wrong blood type is given to the wrong patient. The exact incidence of unintentional ABO-incompatible transfusions is actually unknown, but it's estimated to occur in somewhere in 1 in 38,000 to as high as 1 in 70,000 red blood cell transfusions. Now, for decades, acute hemolytic reactions were the leading cause of transfusion-related mortality, but that has now been replaced in the last couple decades recently, really, by the recognition of TRALI, transfusion-related lung injury, acute lung injury, which we're going to talk about. So now let's look at fun facts about acute hemolytic reactions. The severity of this acute hemolytic reaction is extremely variable and usually depends on the rate and total volume of the administered ABO-incompatible blood. However, 47% of the recipients of an ABO-incompatible blood show no effects even after receiving a full unit. And 41%, only 41%, show even any symptoms of getting the wrong blood type. The mortality, however, of overall blood transfusion mortality is 2% of all the different reactions. So let's talk about febrile non-hemolytic reaction. It's defined as a temperature increase of greater than 1 degree following transfusion in the absence of any other cause for a fever. The reaction may occur up to 1 to 2 hours following the transfusion, and reactions with chills or rigors with no fever actually are also classified as febrile non-hemolytic reaction. They're also the most common transfusion reaction that we have. The incidence varies actually. It varies with someone's age. It varies if they've had a prior transfusion, the type of transfusion, and some underlying illnesses they may have. So now let's look at a fun fact with febrile non-hemolytic reactions. They're more likely to occur in transfusion of platelets rather than red blood cells. In fact, many studies have been done, and they found somewhere between, different studies say different things, pretty wide range, but somewhere between 1 and 38% of platelet transfusions give this type of reaction, and only 0.01 to 6% of red blood cell transfusion give this type of reaction. So literally more than a 10 to 50 times incidence when you give platelets. Interesting. Women with a history of multiple pregnancies are a much higher risk for this type of reaction. So let's look at allergic reactions. Allergic reactions are common. Severity levels include a mild anaphylactic and even an anaphylaxis type reaction. The severe anaphylactic reactions, though, are much less frequent and are estimated at 1 to 20,000 to somewhere between 1 and 50,000 of all transfusions. These type of reactions occur in about 1 to 3% of transfusions of plasma-rich components, the platelets and FFP. That compared to only a 0.1 to 0.3% for red blood cell transfusions. So again, about a 10-fold increase in the reactions when you give patients FFP or platelets. So now let's talk about TRALI, transfusion-related acute lung injury. It's a serious transfusion adverse reaction characterized by acute onset of pulmonary edema with severe alveoli capillary leakage. So that's the important thing when you have TRALI. It's a sudden onset of pulmonary edema, and the alveoli capillaries have leakage going on. It's a very bad thing to be faced with. So the typical presentation of TRALI is the sudden development of dyspnea, hypoxemia, hypotension, and fever that develop within about 30 minutes to as long as 6 hours after the transfusion. So now let's look at a fun fact with TRALI. Again, it's more commonly associated with plasma-containing products, the FFP and platelets, which account for between 50 to 63% of TRALI fatalities. It's the leading cause, according to the FDA, of reported deaths related to transfusion in the United States. It's the leading transfusion-related incidence of death. Now, clinically, it's often impossible to distinguish TRALI from other acute respiratory distress. For instance, TRALI is clinically indistinguishable from ARDS. So now let's talk about transfusion-associated circulatory overload, TACO, right? It's basically congestive heart failure appearing immediately after a transfusion. And basically, it's exactly what it sounds like. And this is a fancy way of saying it's blood circulatory overload. So it's defined as a clinically adverse expansion of the intravascular volume that occurs when blood components are given and they exceed the cardiovascular ability to handle that additional volume and that additional workload. So this may occur as a result of some degree of pre-existing cardiac failure. That makes sense. And it cannot accommodate the additional volume, or it can be due to too rapid of an infusion of a large volume of fluids, mainly including blood in this case. So let's look at a fun fact with TRALI. Believe it or not, patients that are greatest at risk are infants. Makes a bit of a sense because you have to be very sensitive with their volume. But believe it or not, people above the age of 60 have a higher risk of this happening to them. The other ones kind of make sense. Patients with compromised myocardial function, patients that have renal failure or congestive heart failure patients, those are basically usually unable to handle large fluid or already fluid overloaded. And TACO is estimated to occur in only about 0.1 to 1% of blood transfusions. Let's take a look at a delayed transfusion reaction. Post-transfusion purpura. Maybe some of you have heard of this, maybe you haven't. Post-transfusion purpura is a rare transfusion reaction, and it results in a sudden severe thrombocytopenia. Now this develops on average 9 days, ranging from 1 to 14 days. The average is 9 days of onset after a blood component transfusion has been given. A fun fact about this: serious disorders are only seen in multiparous women or in patients who have undergone previous blood transfusions. And because of that, the female to male ratio in affected patients is 5 to 1. This reaction is most often implicated in transfusions of red blood cells compared to the platelets and plasma, as we talked about in the other ones. Now this has become even more rare since we've introduced leukoreduction of the red cells because it tends to remove the instigating antigens. Now let's talk about another delayed transfusion reaction, something called iron overload. This one I find very interesting. It's a common and serious complication of chronic red blood cell transfusion. Now this is often seen in patients with some type of hemoglobinopathy like thalassemia, sickle cell. You can also have it in myelodysplastic syndromes, aplastic anemia, hemolytic anemia, refractory sideroblastic anemias. And so what you're seeing here is that each red blood cell unit has approximately 250 milligrams of iron, but the FDA daily intake for iron in your diet is only supposed to be 18 milligrams per day. So you can see 1 unit of blood, how much iron is there. So these people who have to come back either once a month or twice a month, whatever it is, depending on their condition, those people of conditions I just listed there, these people have to come back because of their persistent anemias. This chronic transfusion can lead to a gradual iron accumulation in the tissues, and this causes morbidity and mortality. So that's a fun fact about this. Iron metabolism is altered in transfusion-induced iron overload. Once transferrin, that's your iron-binding protein in your blood, once that's saturated, the excess iron circulates as free iron and is then taken up by your organs like the liver, heart, lung, and endocrine organs. Iron accumulation in these tissues over time is what leads to end organ damage. Early cirrhosis has been seen in children as young as 7 years of age with thalassemia. Cardiac hypertrophy and dilatation is also common and is a leading cause of death among transfusion-dependent patients. Now let's look at massive transfusions. The transfusion of large volumes of stored blood products may lead to a number of complications. So we're talking about, if somebody's bleeding massively and you're having to transfuse somebody massively, of course you can have a dilutional coagulopathy with the volume overload and the loss of the blood. You can have a circulatory overload, TACO, that we talked about. These are all in massive transfusions. You can have something called citrate-induced hypocalcemia. You've heard of that probably. Hyperkalemia can develop. Massive transfusion is arbitrarily defined as transfusion of more than 10 units of red blood cells or replacement of one's blood volume in a 24-hour period, or a 50% blood volume lost within 3 hours. So let's talk about each one of those. So let's look at citrate toxicity. Sodium citrate is the anticoagulant of choice used in blood collection. In massive transfusion, excessive amount of citrate can produce a transient hypocalcemia and hypomagnesemia, actually, that may affect the cardiac rate and function. What's a fun fact about this? It's usually seen only in patients with liver failure and or severe hypothermia where the citrate metabolism is slowed. So two things are happening. Your liver metabolizes some of that citrate in addition to some of it binding the calcium. Treatment with calcium and rarely magnesium is tailored to the clinical findings and the ion levels. Now, in trauma, there's a general rule among trauma surgeons that 1 gram of calcium is given per every 4 units. That's just sort of a rule of thumb. You wouldn't really have to be that aggressive, but that's kind of a rule of thumb in trauma, and some of you may see this in your practice, even in cardiac. So let's talk about hyperkalemia. Storage of red blood cells causes the intracellular potassium to leak out of the supernatant. This is progressive and thus more significant in the older blood stored units. Older units have increased hemolysis also, which really releases potassium because, as you know, potassium is an intracellular ion. The total potassium dose in transfused red blood cells is only about 0.5 milliequivalents in shorter storage red cells, handful of days, but as high as 5 to 7 in units that are close to their expiration. So what's a fun fact about hyperkalemia? The irradiation of the red blood cell units that we're all sort of fond of, this actually accelerates the potassium leakage into the plasma of the stored unit. So let's look at gaps in our knowledge, just some fun facts in general about blood transfusions. In the last 35 years of research, has demonstrated that patients transfused according to current standards of practice experience striking increases in morbidity and mortality when compared with non-transfused patients, or patients even receiving fewer transfusions. Now, you probably all have heard that, but interestingly, patients that are undergoing cardiac surgery have significantly reduced mortality and multi-organ failure when randomized to receive only leuko-reduced transfusions. So the leuko-reduced transfusions have shown to be beneficial. But even those leukotransfusions are still associated with increased morbidity. So transfusions are associated with substantial increases in venous and arterial thromboses, raising the question whether transfusions alter recipient platelet and endothelial cell function. Patients with acute coronary syndrome, patients that have acute coronary syndrome, maybe they didn't need blood, maybe they did, maybe they were given blood because they felt it would help them. But if you give a patient experiencing acute coronary syndrome, they experience a dose-dependent increase in MI and mortality if they are transfused with red cells, according to observational studies. Okay, that's all I have, Joe. And,
wow, that was actually fun.
It was interesting.
That was great. That was fantastic. I do have a couple of questions though, if I could, before I do mine. Can I go back to John's slides? I'm sorry. And I want to go to, I don't remember, let me get to the slide.
There's the outline there. You can go back a couple slides and see the outline and see if it refreshes you as to where you...
Yeah, I'll find it.
Okay. I didn't know what the time constraint was, so I hope I didn't go a little too fast.
No, not at all. It was pretty fast, but it was great.
Yeah, I tried to make it powerful as much as possible.
Here it is, right here. Okay. No, that's not it. That's it, right there. Many publications suggest that the need for transfusion should be carefully evaluated, avoided when possible, and considered only as a last resort life-saving measure.
Well, that's why I put it in quotes. That statement's a little aggressive, a little over-aggressive. And this article, just so people know, this particular review article, it came down on the negative of blood transfusion whenever possible. And I used it because it was so comprehensive. It covered even way more than the things I covered in my talk, and it used an enormous amount of references. But it was a anti-blood donation slanted article that you should keep in mind. And it's not used only as a last resort life-saving measure. It's used when patients are unstable and just need and are hypoxemic. And I kind of inserted that when I was talking through this sentence, but I probably should have added it, but it's a quote from the paper, so I couldn't change it.
No, I don't think you should have either. I think that but I do think that it's worth us discussing it. And I'm done. I'm good with this slide though. Thank you. I think that that's an issue with this whole thing. Is that there's two camps. There's all blood transfusions are bad, and this other camp of let's just give blood, 1 unit. If you're going to give one, you may as well give two. And neither will the two meet. Right. So I do think that we have to be judicious with the use of blood and use it appropriately. But I don't know if you've seen the articles, but newer blood, fresher blood, if you will, blood that has not been stored for 42 days but only stored for 5 days, has much higher viability, much better. You don't have depletion of your 2,3-DPG, the potassium levels, and hemolysis is of course much lower. You don't have the elevated potassiums and so forth. And I'm concerned that the storage of blood being up to 42 days is just frankly too long.
It's an awful long time.
Yeah, it is. It's a very long time, but that is the limit. That's the allowable limit. I used to practice. I don't know if you've done this yourself, but if I called for blood and I got it and it was going to expire tomorrow, I would tell them send it back and get me a unit that is within the past 7 days. And the lab used to get really upset with me, but the blood bank. But I got it. I wasn't going to give that blood. But because I do think you have to recognize it is also about DO2. If you don't have enough oxygen carrying capacity in your blood, then the patient is going to have a higher heart rate. You're going to have to you may have an tissue oxygen deficit. There are real consequences to having anemia, and each patient is going to be a little bit different. especially on cardiopulmonary bypass, but in the postoperative phase where you just got through operating on a heart that started off with a 20% ejection fraction because of acute coronary syndrome and a failed PTCA, and now you're in the operating room. And they, you come out of there with a hemoglobin of 6 or 7, they don't do well. So they, what do? Do you manage the patient today to get through to tomorrow, or do we worry about what might happen in 5 or 10 years? I know it's a different animal than massive transfusions and, for other disease states. I'm really sort of bringing it into the cardiovascular perfusion realm, if you will. What's your view on transfusions? How do you feel?
Well, having I'm not a pediatric perfusionist, but we do have peds here at this hospital, and I run by them occasionally. But having our pediatric perfusion counterpart colleagues adopted this as standard of care. Don't they only give blood that's less than 5 days old or 7 days old? They have a cutoff. They will only give very, very recently donated blood. Mm-hmm. They don't tolerate units past. Somebody can call in who's a pediatric perfusionist. I think it's 5 days or 7 days.
Yeah, it's very
beyond
short.
That. They won't entertain giving it at all.
You're absolutely right. And then of course they also take their blood and wash it. They use the cell saver, the auto transfusion system. They wash their red cells before they give it to the patient. I wonder if we shouldn't all do that.
There's enormous benefit to that. I was reading about that, not only in this article here, which I used, but other articles affiliated. Washing the red blood cells, most people, I think, probably don't want to be bothered with it and think maybe it's not terribly necessary. But if you look at the studies, there's some definite benefits to washing bank blood before you give it to the patient.
Mm-hmm. Absolutely. And then one of your fun facts, if I can, do you know what the number one cause of death is associated with blood transfusions?
No.
Clerical error.
Yeah, that has been talked about in so many blood transfusion talks that I saw that and I elected not to put it in, but it actually, there's 3 levels to it. One is the phlebotomist who drew the blood from the patient made a mislabel on the lab tube. Mm-hmm. It's not only two people looking at a blood unit and looking at it and still somehow giving it to the patient. Those days probably are very rare now, but you have 3 levels. The phlebotomist who draws it mislabels the tube, something happens in the blood bank, and then something happens in the OR. Mm-hmm. And between all 3 of those, when you think about it, somewhere along the line, it might happen every now and then.
Absolutely. I think it's very unlikely to check a unit of blood now at the bedside or the ICU or in the operating room and give the wrong unit. I think it's very difficult to do, but it can still happen. It can still happen.
We had 2 patients with the identical name, and only a 1 or 2 numbers different on their medical record number.
Yeah, and I think that's alerted now.
We had 2 patients with the identical name on ECMO.
Yeah, that's amazing. Amazing how that can happen. And that's, and I think now they have systems where if you have that in a hospital, there's some alert on both of their names that there's another patient with the same name or close match or something like that. I've seen that at least a couple of times. Okay.